Good afternoon, everybody. Thank you for attending this wonderful program, and thank you, Dr. Sandy Manganya, for an excellent presentation and a wonderful introduction to our current panel. As you can see from this slide, a number of active participants and supporters to this particular program. And we're going to have, next please, Selene.
Oh, okay, now it's not, oh, there we go.
All righty. So these are the presentations we're going to have, and I won't go through them now because you will not only see them, but you will hear them, and you will be enriched, and they will all complement and supplement and enhance what Dr. Maganyan has already said. Next. I do want to point out, if you look to the left of your screen, there is a Break the Cycle framework. And this is based on a not-for-profit called Break the Cycle of Health Disparities, exploring the social, economic, and environmental determinants of health. And this is exactly what we're talking about when we talk about health disparities: social, economic, environmental, and what's not in the slide, political as well. So what we have done is taken this concept of a cycle, next please, Selene, and we put it into the framework of autism disparities. Now, for the most part, the disparities have a basis in low income and minority status. If you look at the top of this slide in this sort of lilac-y color, it says low income and minority status. And if you follow the cycle clockwise, you'll see it says limited diagnostic resources. And Dr. Manganya pointed us out very well, not only limited diagnostic resources, but also limited therapeutic options. And as a result of these limited resources, there's delays in therapy. And she had that wonderful slide which showed her research demonstrating delays in therapy and delays in limited resources. And as a result of delay in therapy, delay in diagnosis, you have delay in making progress. And along with limited educational resources, these kids don't do as well. And if you also looked at Dr. Manganya's slides earlier on, it showed that the non-minority kids got resources early on, and later on, the minority kids got more educational resources. Why? Because they were in special education programs. The kids who had the earlier diagnosis and earlier therapies did not need as much special education later as the kids who did not get the early resources. So I think as you look through the cycle, you'll see there's limited preparation for life and limited minority status. The series of presentations that we're going to give you from our panel will demonstrate how we can look at each aspect of the cycle and how we can break this cycle, because that's exactly what we want to do. We want to break this cycle and promote health equity for all children. Thanks, Selene. Take over.
All right. Thank you so much, Leslie. And it's such an honor and a pleasure to be part of this panel. As Dr. Magnana so nicely pointed out, is that we are getting better, and certainly the CDC's new epidemiological study has shown this. We're getting better at decreasing the disparities that exist. We know now that autism is 1 in 54 children, and the prevalence rates are showing that finally these prevalence rates are identical for non-Hispanic, white, and Black and Asian Pacific Islander children, but they do continue to be lower for Hispanic children. What still persists is that an increasing amount of Black and Hispanic children have intellectual disability compared to only 27% of white children. So you can see for Black children, that's almost double. And that Black children with ASD are less likely to have a first evaluation by age 3 than white children, which is the point that Dr. Room was just making. There is a plethora of research now that show that these disparities exist. The racial and ethnic disparities have shown that African American, Hispanic children historically are diagnosed later than white children. They're more likely to be misdiagnosed with a host of erroneous labels, usually the disruptive behavior disorder or those quote unquote bad kid labels. And they are missed to diagnosis, so some aren't ascertained at all. And we know that these African American Hispanic children also have poor access to health care services and less likely to have a medical home. Interestingly, the research is equivocal in showing whether or not autism symptomatology differs across race and ethnicities. However, we do know that intellectual disability and developmental delays are more prominent in minority children. And a couple studies actually show that African American children are less impaired in their adaptive functioning and actually exhibit less externalizing and stereotypical behaviors than Caucasian children, despite the fact that they are receiving more of these disruptive behavior disorder labels. Now, the research on socioeconomic status also shows disparities in economic, and usually studies will measure this by maternal education or total household income. And unlike other developmental disabilities, there's a positive relationship between socioeconomic status and autism prevalence, meaning that you're going to see more autism diagnoses given to families of more advantaged means. And there have been studies that show that the socioeconomic disparities are actually prominent, and that when you account for these, there aren't racial or ethnic disparities anymore, that it really has more to do with being in a disadvantaged community. But more recent research is showing that even when you control for SES, that the racial and ethnic disparities persist. You'll hear today that children with ASD are more likely to live in geographical areas comprised of adults with higher education and family incomes. So when we look at rural populations and urban populations and more disadvantaged communities, you're going to see higher disparities there. And then we as clinicians have to be aware of our own contributions to these disparities. There is an interesting study that was done that when you give case vignettes to clinicians of identical symptomatology, the clinician will provide an autism label to the child of the more advantaged community and one of these other non-autism labels that are erroneous to a child of a more disadvantaged community. So I want to leave the time for the experts to talk about all the research that they're doing, but here's how you can help. Jareen has a copy of these introductory slides, so you can get them on the website following the conference. But just to highlight here, you can participate in ongoing research and clinical opportunities, including autism service care coordinators needed at Georgia Tech. Contact Jennifer Singh. Compassion meditation for families and health professionals, contact Samuel Fernandez Cariba. Zoom focus groups for research on rural and medically underserved areas, as well as research on transition to adulthood, contact Susan Brasher. So without further ado, I would like to turn the slides over to Teal Benavides, who I'm going to introduce, who will give us our first panel talk today. So while she's putting up her slides, I'm going to introduce Dr. Benavides. She's an occupational therapist, researcher, wife, and mother. Currently, she serves as an associate professor in the Department of Occupational Therapy and in the Institute of Public and Preventative Health at Augusta University. Dr. Benavides aims to address the most pressing medical and mental health priorities faced by the autism community in collaboration with autistic partners. An extension of this work seeks to understand and reduce racial and ethnic disparities and care for individuals on the autism spectrum here in Georgia. Her talk will focus on the association between economic disparities and higher rates of missed autism cases here in the Georgia Public Schools. So welcome, Dr. Benavides.
Teal, if you're speaking, we can't hear you. You should unmute.
Hold on, let's see if we can unmute her from our end.
You're okay
There we
now.
go.
You're okay.
Can you hear me now?
Yes.
Okay, good. So my name is Teal Benavides, and I'm so pleased to be able to share this presentation on behalf of Dr. Brian Barger at Georgia State University. This preliminary and exploratory study is really aimed at understanding factors that are not usually investigated in relation to social determinants of health. As we know, there's a large body of literature that suggests that differences in access to services are not accounted by actual need for those services. And Dr. Magana's extensive work has illustrated these disparities in a variety of ways. Most of the disparities work that has been presented suggests that child and family factors such as race and ethnicity or insurance status predicts lack of service receipt. However, very few studies look at the county level predictors that are associated with autism service receipt. The purpose of our study, and can you go ahead and advance the screen, Jareen? I can't control your screen.
Yes, I'll do that for you.
Thank you.
Are you here now?
Yes, thank you. So, okay, so the purpose of our study was to identify rates of potentially missed or unidentified children with autism spectrum disorder using county and state level education records in Georgia, and to understand those county level sociodemographic factors and the relationship to those rates of potentially missed cases. Our primary outcome variable were children who are unidentified or potentially missed from Georgia school districts. What we did, because unidentified children are unidentified for a reason, it makes it hard to know if this number is a true number. We used an epidemiological approach to compare the known number of children with an educational classification of autism from a particular county in Georgia. And we compared those epidemiological rates to those from county estimates of the total population of children in that county based off of US Census records from 2013. We were then able to use the CDC prevalence rates to anticipate how many children we would expect in that county and compare the actual autism classified children to the number we would expect. And so what we did was we created this potentially missed rate of cases, and we looked at county level factors that were associated with that outcome. Go ahead and advance, Jareen. What we examined in terms of factors at the county level associated with potentially missed cases was the rural or urban status of that county in Georgia, the median household income for that county, the percentage of minority individuals living in that county, the high school graduation rate, and we controlled for the number of primary care providers in that county per 100,000 people. And therefore, we were able to control for a variety of factors that you might consider impact access to care at the county level. All of these variables were publicly available and were able to be accessed through a number of different sources, which I'm happy to share with people at the end. Go ahead and advance, Jareen. We use linear regression to evaluate the association between these county factors and the rates of unidentified children in each of the Georgia counties. Go ahead and move to the next slide, please. So what did we find? Here in Georgia, there are 159 counties, and of them, 113, or approximately 70%, had available educational data on children with an autism classification in 2013. Those counties that did not have educational data were significantly more likely to be rural and have lower counts of children overall than those counties with data. And this is expected because those counties without data sought to protect the identity of the low rates of children identified with an autism classification. And so therefore that data was likely suppressed and not just unavailable. What we found in our regression model was that the only statistically significant factor that was associated with missed autism rates was county level median household income. And let me share a picture of what this looks like so that we can understand this better. Jareen, do you mind moving to the next slide, please? So what we found in our regression was that for each $10,000 reduction in median household income at the county level, the unidentified autism rate increased by 6%. That's a huge number of children that are missed based off of the household income levels of the county. And in our study, the Georgia counties that had more than 60% of missed cases, as expected by the epidemiological estimates, were significantly more likely to have median household incomes in that county of less than $40,000. In this map that you see on the screen, those counties with more than 60% of unidentified or missed potential cases were those that were also likely to have less than $40,000 median income at the county level. And these counties surround the greater Atlanta region. And even though we adjusted for the number of primary care providers and other factors, the main thing that predicted missed autism classification was the county income. So this exploratory analysis points us in the direction of really understanding those system level factors that contribute to disparities. Although it's important to understand individual and family level factors, we really need to be working to understand system factors so we can develop and better implement system level changes to address these disparities in service access and receipt. So even though we think that there are missed cases in these counties, it's likely those children are potentially either receiving services under another classification and are going without an autism classification, as Celine mentioned, or they are completely unidentified and are being labeled as some other emotional or behavioral disorder. We really need to know more about county level factors that influence receipt of services. And this preliminary study suggests future directions that we can go to understand these disparities in access. Some things at the county level that are related to this, but which we did not understand, is how those school districts have resources to both provide services and work with families to address their needs. Some additional limitations to our study is our assumptions about missed cases and our epidemiological approach, and the lack of complete county educational data. In some of the counties that you notice with red dots, we did not have data, and we really need to more completely understand those very rural counties. Thanks so much for your attention, and I'll take questions at the very end of this panel.
Thank you, Teal. That was a wonderful presentation, very sobering but important findings. Our next presentation will be from Dr. Susan Brasher. Dr. Brasher is an assistant professor at the Emory University School of Nursing. Her background includes being a certified pediatric nurse practitioner and registered nurse. She obtained her PhD in nursing with an emphasis in pediatric neurodevelopmental disorders, specifically autism spectrum disorder. She is committed to working closely with children and young adults with ASD to minimize health disparities and improve health outcomes. She's also one of the few experts in adult females. Her talk will address disparities in children with ASD living in rural and medically underserved areas. So welcome, Dr. Brasher, and thank you.
Thank you. Can you hear me okay?
Yep.
Okay, great. Thank you. So today my talk is going to be looking at addressing disparities in children with autism living in rural and medically underserved areas. So first I want to acknowledge the findings that I'm about to report are part of the presentation, partly supported through the Break the Cycle program alongside my colleague, Dr. Jennifer Staplewax, and student mentee, Amy Bloomling. So as we've heard today, the evidence shows early diagnosis and treatment improves health outcomes of children with autism. And we know that a valid and reliable diagnosis of autism can be made by age 2. Yet the current average age of diagnosis is much later at about 4.5 years old. And these delays in diagnosis and access to treatment services more profoundly impact families of children with autism living in rural and medically underserved areas. Yet little is known about the health disparities encountered by these families and ways to effectively minimize them. So the purpose of this project was to identify barriers and facilitators to autism diagnosis and treatment for families living in these rural and medically underserved areas. So first, let's talk about what is the difference between a medically underserved area and a rural area. And I think for a lot of us, when we think of rural areas, that comes pretty easily to mind. It's these geographically remote areas that have fewer than 2,500 people, as you could see over here. But often overlooked are the medically underserved areas, as you can see on this side, is that these are often densely populated. They could have a Starbucks and Super Target, but what they lack is a hospital and medical providers, which is necessary for autism services and diagnosis. So we wanted to reach the families that were residing in these areas. And so this talks a little bit about how we were able to reach these families. So we leaned on our local specialty clinics from which the participants were coming to visit from these areas. We also reached out to rural pediatric clinics. We heavily relied on the social media support groups. So the Facebook support groups was a really good part of this project. We also pivoted to our established partnerships with the Marcus Autism Center, where these families were traveling from these areas to receive the diagnosis and services at Marcus Autism Center. And then we formed a new partnership, which was really important, and through the Department of Education and through their parent mentoring program was really critical. So we held a series of focus groups, and we tried to make them in person as much as possible. And when not possible, we held them via Zoom. And this just gives you an idea of the families and where they resided throughout Georgia. And so you can see we looked at rural areas, which are here in blue, but we also looked at the medically underserved areas, and we targeted our recruitment to these areas. And so you could see we had a pretty good spread out, which is why sometimes Zoom was so important when we had one over here and one over here. So what did we hear from the families? These are just some of the quotes I wanted to share with you about why their child was not diagnosed as early as possible. One parent said, "We went to Babies Can't Wait and they sent us to a school therapist. Then that person sends to a pediatrician. Then my pediatrician sends to a psychiatrist. And then the psychiatrist needed to see my child in 2 different appointments to make the diagnosis. And then it took another 6 months between those 2 appointments to finally get the diagnosis." Also, I feel like even when trying to get an appointment for an autism diagnosis, there's a waiting period and it takes forever for someone to see your child. And the doctor wouldn't diagnose him with autism because he said my son was fine, just because he walked and he physically looked fine. So here's a word cloud of the themes that we heard from the parents on the barriers to diagnosis. So as you heard, wait times was a really big one, insurance, the distance, redirection, as we also heard from by providers, limited provider education, limited number of providers in their area to make an autism diagnosis. And then next, we wanted to hear about the barriers to treatment. So this is what we heard. "Me and my husband both work full-time jobs, and my child going to school every day. That makes it really hard to find some place that works with our schedule." And then one person said, "I have to drive either an hour east or 2 hours west to take my child to his appointments. And my main issue was insurance. You know, insurance don't cover this or insurance don't cover that, and I couldn't afford to pay out of pocket." And so here are some of those themes again: distance being a really big one, insurance, cost, lack of school therapies in some areas, the limited number of providers in their area to provide treatment services, and the cost of accessing these services. And then the facilitators and what helped to get their child diagnosed earlier or to get services are here. So what was nice was the therapist from Babies Can't Wait came to our house and worked with him in our own home. And because of the history of my other child being diagnosed with autism, they didn't even want to fight me. And she got an appointment and started therapies within weeks. And then a counseling center here in town started Skyping the psychiatrist into the clinic. And so we were able to get the services here. And so here are some of those facilitators, again, a sibling being diagnosed. Our state programs such as Babies Can't Wait really helped. Facebook support groups, in-home therapies, insurance extenders like the Katie Beckett, and community fairs all help for them to receive services and get a diagnosis earlier. So where do we go from here? We need to have additional focus groups in these rural and medically underserved areas, but we also need to go further and create a deeper engagement with the families and stakeholders in these areas. We need to increase our training and our education of providers, and we need to provide better access to care in these rural and medically underserved areas. And we can do that through telehealth, through mobile clinics, and then also by partnering with regional and state universities to allow the students to have their clinical hours and receive training to go into those areas. And I just want to say thank you for attending my presentation. I'm happy to answer any questions at the end. And here's my contact information in case you want to reach out to me.
Thank you, Susan. That was fantastic. Our next presentation is going to be from Dr. Jennifer Singh. Dr. Singh is an associate professor of sociology in the School of History and Sociology at Georgia Tech. Professor Singh investigates the social and structural inequities of autism services in Metro Atlanta, and she's currently conducting analyses of over 70 interviews and surveys she conducted with low-income and minority families of children with autism. Her talk will cover a model of care for underserved families of children with ASD. Welcome, Dr. Singh.
All right, thank you. Can you all see me? I can't see you, but I'm really excited to be here. Let me start from the beginning. First of all, I just want to say how excited I am to be here. And the work I'm sharing with you today is just work that I've been doing over the last several years in collaboration with Dr. Leslie Rubin, which is a quantitative and a qualitative study that is assessing the quality of the care provided by a community-based autism clinic here in Atlanta that serves primarily low-income and underserved minority families and children and their families. And I just want to highlight with this first slide that this project involves many collaborations, and our most recent is with Dr. Stephanie Wagner. I officially became a doctor a couple of weeks ago from Emory University. All right. And as we've learned today, disparities at the intersection of race, ethnicity, and or social class, as well as other forms of difference, really exist in many domains of autism care, including delays in diagnosis, the type of autism classification a child needs, as well as different access to services. And I just want to highlight that there's also disparities in the quality of care, which we've learned some from today from Dr. Magana. Studies have found that family-centered care, so these such as, spending time with the doctor or feeling like a partner in care, really differ for white compared to Black families, where Black children are less likely to receive family-centered care practices. Some studies have indicated that providing adequate family-centered care can perhaps mediate the negative health outcomes due to race and ethnicity, whether it be unmet therapy need, overall health adjustment and life outcomes, as well as family emotional distress and increased family satisfaction with their child's care. To date, there's just been very little work to really understand how racial and ethnic minorities, families with limited resources experience family-centered care as well as care coordination. And so the purpose of this study was just to really evaluate the quality of care that's provided by a community-based autism clinic.
Jennifer, I'm sorry to interrupt. Can you put it into presentation mode?
Oh, is it not in presentation mode? Sorry.
No, we're just seeing the whole set of slides. We're not appreciating each slide.
There we go. How's that? Better?
Not yet showing. There it is. Perfect. Thank you.
Okay. All right. I think the problem there is that I couldn't see my notes. Okay. So the purpose of our study was to evaluate the quality of the care provided by a community-based autism clinic. And we did this by conducting a survey as well as interviewing caregivers who received services at the autism clinic for their child. The survey measured 3 measures of quality of care: accessing care, family-centered care, as well as care coordination. And we adapted the questions from the National Survey of Children with Special Health Care Needs, which is a large population base survey that's conducted by the Center for Disease Control and Prevention. And so while I was administering the survey, I also asked a lot of follow-up questions about what families meant in terms of how they responded to the questions, as well as some of the barriers that they experienced before, during, after their child received a diagnosis. And for today's talk, I'm just going to focus on two outcomes, family-centered care and care coordination, where we're comparing the quantitative measures with national and state level data, as well as contextualizing the quantitative data that we generated with qualitative interviews. And to give you a little bit about the Autism Clinic at Hugh Spalding, it was developed in 2002 by Dr. Leslie Rubin to address the needs of low-income and minority families with autism and developmental disabilities in Georgia. It provides a comprehensive continuum of care. So families come in and they're able to see a developmental pediatrician, nurse practitioner, speech and occupational therapist all in one visit. And they have access to other services as well. The clinic runs 3 days a month and, you know, offers diagnosis, medical management, as well as referral services. And many of the families that come in through the clinic do rely on Medicaid, and there's a large racial, ethnic, and economic diversity that comes into the clinic. And so this graph, or this table, just shows you demographic data that we collected. And so what I want to point to, and maybe I can use my pointer here is our data here. And we're comparing it to national data that was collected from the National Center, or in the National Study of Children with Special Health Care Needs, of children that had autism, as well as Georgia data. And this is work that Stephanie Wagner did. And what I want to highlight here is that our sample is predominantly African-American, or children who participated, whose parents participated in the study, self-identified as Black. And we have a larger percent that are single, so either separated, divorced, never married. We also have a large percentage of families that rely on public health insurance compared to national and Georgia data, and live at or below 200% of the poverty line. And so really need to think about the differences that we're seeing just in the demographics of the data collected when we're trying to understand different measures of family-centered care. And so this table really shows different measures of quality of care. So we're looking at family-centered care. And what we find is that the Autism Clinic really does wonderful in this domain. Whoops, I didn't mean to do that. Compared to national and Georgia state level data. And so in the red, the providers spending enough time, providers listening carefully, providers giving specific information, and discussing a range of options for their child, all were significantly higher than national and state level means. And so these are areas where the clinic is really performing well. And if we look at qualitative data, this sort of helps us understand what this actually means to conceptualize these findings. That family-centered care measurements of spending enough time and listening carefully were discussed in the context of allowing caregivers enough time to ask questions, voice concerns, and spend time with multiple providers who shared a genuine interest in their child and their family needs. The clinic also ranked high in providing comprehensive and clear information about autism, which can be very complicated, and offering a list of referrals for therapies and other needed services. However, there were limitations to family-centered care that were voiced by our participants to this approach. That were the length of the time of the initial visit was oftentimes overwhelming for both the caregiver and the child, which was compounded if there were competing priorities, such as the need to go to work, the need to care for other children, or maybe even transportation limitations. Meeting different providers whose specific expertise was unknown in relation to their child's needs was also a point of concern. And at times, parents felt this was sort of repetitious. And for those caregivers who are really new to autism, the amount of information provided was also a point where parents felt overwhelmed. So this second set of data looks at care coordination. And again, it's comparing the data that we collected on questions around care coordination compared to national and state level data. And what we found is that the Autism Clinic was significantly less likely to offer, from parents' perspective, care coordination needs. And as well as they felt that they needed extra time, extra help coordinating their care compared to national and state level data. And again, the qualitative data really demonstrates that among caregivers interviewed, the Autism Clinic did not necessarily provide care coordination, but rather offered referrals, resources, and a really an initial step forward for families to follow up on. And as a consequences, most of the care coordination was done by the families themselves. They just basically said, I'm doing all of this work. And it was largely mothers, a handful of grandmothers, as well as a large percentage who were single parent coming from a single parent household. The qualitative data also revealed that the kind of help needed when it came to care coordination reflected a lot of the social and the economic vulnerabilities faced by many of our participants, including help finding needed services, which were limited due to cost, insurance coverage, and as we saw from Susan's talk, location of services and therapies. Caregivers also wish that there was more therapies that were centrally located, offered maybe evening and weekend, options, or provided daycare while their child were getting services so that they can actually be involved. Two other areas of concern that were highlighted in the context of help needed when it came to care coordination was the need for caregiver mental, physical, and emotional care. And while this type of coordination was outside of our definition of care coordination when we asked the question, the caregivers, this is how they responded. And these areas of need really highlight the importance of considering the complexity of care coordination, not only within the ecosystem of providers, but also the social, the emotional, and the economic context of family and their children who are living with autism. And so I just want to conclude with our evaluation that identified the strengths of quality of care offered by the clinic, which supports their multidisciplinary model, and genuine care for the family as a unit. A model of care particularly effective for underserved families because they're able to see, 4 or more providers in one visit, which can, really start creating a cohesive unit in terms of their child's care. The effects of feeling valued, respected, and heard, cannot be overestimated. However, there are needed areas of improvement, including the development of multilingual information sheets about the types of providers and the services that they're receiving, as well as really what to expect during their first visit. Addressing the structural inequities in care coordination will require system level changes. So while we're seeing family-centered care really working well, it's that next step that we're seeing barriers. So for now, we recommend a designated autism clinical care coordinator, a specialist that works with Medicaid systems of care in Georgia, as well as a parent advocate who can really help the diverse needs of underserved families. Thank you. And I just want to highlight, and I will share these slides. There is a breakout session that I'll be part of next Tuesday that is considering issues around COVID-19 and autism disparities.
Thank you so much, Jennifer. You raised some really good points, especially the communication between providers and families. And it's a nice reminder for those of us who conduct these diagnostic evaluations that even though some of us have done this hundreds, if not thousands of times, the family sitting across from us, it's for the first time. And so it's really good research that's being done. Okay, we're moving on to another Jennifer, this one, Dr. Jennifer Staple-Wax. Dr. Staple-Wax is an associate professor in the Division of Autism and Related Disorders within the Department of Pediatrics at Emory University School of Medicine. She's also on research faculty at the Marcus Autism Center, which is Children's Healthcare of Atlanta. She's worked directly with children and families for over 25 years in doctoral level research, clinical practice, and graduate level teaching. Her specialties include assessment of young children, neurodevelopmental disorders, early intervention, and consultation liaison in multiple systems of care. Her current focus is to lead community-based research and outreach projects for infants and toddlers at risk for ASD. She also provides leadership for community-based projects with a focus on universal design, early brain development, and prevention. Her talk will focus on the importance of access to early intervention for all children. Welcome, Jennifer, and thank you.
Thank you. Welcome, everyone. So I'm going to talk a little bit today about the power of early intervention. And for many of you, I am preaching to the choir. You all understand how incredibly important this is. But I know when we're talking about trying to provide care that reaches all children and all families equally without disparities, we really need to consider how incredibly important this period of time is, early brain development. And I'm going to highlight a couple of projects that will lead us up to what can be some really inventive and innovative work that we've been able to do as a result of COVID-19. Let's see here. So really, we want to talk a little bit about the growing baby's brain and how we're building early skills, and that the available workforces and providers, and most especially parents and caregivers, are really in a unique position to be able to address the needs of very young children, and how our knowledge about early brain development really informs our evidence-based and community-oriented approaches. So many of you may know, and just to familiarize you with this, that the brain doubles in size in the first year of a baby's life, and the synaptic density quadruples. And brain is really growing very, very quickly during a period of time in which we are often either missing the signs of early developmental delay and potentially autism, or we're going back and forth. I've heard folks say before today about the wait and see approach, or we'll just wait another 6 months and see what happens. And all during this time, the brain is growing and developing in response to what's happening around the child in the environment. And the majority of that brain development is completed by the age of 2 years, and certainly quite a bit done by the first 5 years of life. And so it really punctuates for us the incredible importance of getting to children with intervention. And also this whole idea that brain plasticity changes dramatically, that children are very plastic in their brains. They can change quite a bit. And so we have a great deal of hope if we can identify early delays and thus channel children into early intervention. And really the large focus of my work has been to reach children at the earliest stages possible, to begin to look at what are the delays that we can be addressing. And certainly we're all clear about what the building blocks of development are, but I think that one of the ways in which we make a huge impact is that we go to the people who are most likely to be observing development in these areas and give them really key milestones to look at, to track the development of children. Think about parents who are watching their 6-month-old move to 9 months to 12 months. What is it that they need to be looking for, and what might be considered a red flag or a risk factor for a child who's not developing in one or more areas? And for children with autism, those areas often are very much in the areas of language and communication, social communication, and emotional regulation. If we look at the number of babies born each year in the United States, about 4 million babies, 12 to 15% of infants and toddlers presenting to well child checkups are going to have an actionable delay. And this results in close to 600,000 children who may have an actionable delay. And how that translates to what we see in our own state is that there's almost 100,000 children delivered yearly. And so we're looking at 16,000 children in a year have actionable delays in this first few years of life. 1 to 2%, as many as 2,000 per year, may have autism. And so that's a lot of kids being funneled through a system and maybe not necessarily being identified early enough. And so we see that there's this real need for early screening and detection and timely identification and diagnosis. And those are often the bottlenecks that keep us from getting children into early intervention. We have a Part C Babies Can't Wait process in Georgia that can see children as they are developing these early delays, and yet many of those children don't reach that system in a timely enough manner. And so we really are looking at how are we mitigating delays and building skills in social communication and emotional regulation, and potentially having an innovative goal. It doesn't sound so innovative because we think it should be everyone's birthright to be school ready by 5 or 6 years old. And we know that early intervention, that most children are missing it. They are just not being identified early enough to take advantage of it. So they're neither taking advantage of what's available through the Part C system, but they're also not able to take advantage of the early brain development that's so plastic and would allow them to build skills and potentially avoid more challenging behaviors that are arriving as a result of delays in skill. So what is it that babies need? Well, infants and toddlers need active engagement and play and functional spontaneous communication opportunities. The way that this is going to happen best is in a naturalistic environment with family involvement. And so that really means that in order to create new skills for this child, help them maintain them, generalize them to new situations, that we are going to need to help the people who are spending the most time with infants and toddlers. And we need to teach those individuals how to make everyday activities teachable moments. And so everything that a parent or a caregiver, if you are an infant toddler teacher, everything that you do with the children in your classroom becomes a teachable moment, whether it's the changing of the diaper and the talking that's happening at that time, going to the grocery store, book reading, getting dressed, taking care of your teeth or your face or washing your hands, all become teachable moments. But how to make those relevant and teaching of social communication and emotional regulation is something that parents and infant toddler teachers really can be coached to do. And we heard Dr. Magana mention naturalistic developmental behavioral interventions. And these are really thought of the state of the art for children who are on the young side. When we're able to identify children who have risk at 12, 15, 18 months, we really want to be training the parents and caregivers who are with the children the most to spend time doing activities with them that extend their knowledge. And so what we were able to do over the last few years is we were able to work with infant toddler classrooms where we were teaching the teachers to not only recognize early red flags, but then to sort of adjust how they are working within their classrooms to adjust for children who are experiencing delays, using these ideas about everyday moments, good social communication, and emotional regulation. We also were able to reach a high number of Babies Can't Wait providers who also were able to learn to coach the parents that they were working with. And this is already a primary provider approach, is already part of the Part C services, but they were learning how to really target and encourage parents to spend every other wakeful moment that they have with their children, practicing with some of the skills that they are learning from the Babies Can't Wait providers. And we've been able to do this all during those years leading up to COVID-19 via a mobile platform. And we were coaching from the Marcus Autism Center out into the community, using as much technology as we could, seeing what the Babies Can't Wait providers were seeing, and also providing them coaching with bug in the ear technology, as well as video review to really help them learn how to apply these skills. And that was incredibly productive and helpful. And prior to COVID-19, we engaged in an IES study that is looking at the impact of training Part C providers. And we are right now coming to the end of year 2 in that. And I would say that this is, there are not a lot of pluses for many of us around COVID-19, but for us, we have been able to see this study go forward full throttle because these providers are being coached via a mobile platform. And they now, because Georgia made the decision to provide the services in Part C via a mobile platform, those providers are now providing services to parents via a mobile platform, as opposed to not having those families receive services. And we have seen that this has been incredibly helpful in us understanding the viability and feasibility of a mobile platform and how we can coach parents and caregivers to use really solid skills in every wakeful moment in their child's life. So I think my takeaway messages for you is that we have to maximize early brain development, and that we are needing to act quickly and effectively on actionable delays. And sometimes that means we're acting on delays that are a little bit hard for us to yet discern whether it will be ASD, but we know that it's not typical development we're seeing. That we're equipping frontline providers with increased knowledge about autism spectrum disorder, that they have facility with screening and they know how to make good referrals. The parents need rich examples, good tools in education, and there are good tools out there to help them. And put the in-place early intervention providers, give them more increased knowledge and skills and the coaching that they need to be as effective as possible with the time that they have with the families that they're meeting with, and coach them to coach parents. And all of this on the foundation of being both cost effective and feasible. And I think that we're really going to be able to see and document some nice feasibility on what we've been doing in our lab. So I look forward to reporting those results in the future. Thank you.
Thank you, Jennifer. And I have to give you a shout out for making telehealth state of the art prior to COVID. It's really amazing work that you already set the stage for, and hopefully now that's a smooth transition for those families.
Thank you.
So our final panelist speaker today is Dr. Samuel Fernandez-Cariba. Dr. Fernandez-Cariba is a clinical psychologist, certified meditation instructor, and adjunct professor at Emory University School of Medicine. He obtained his PhD in psychology from Universidad Autónoma de Madrid in Spain and completed his postdoctoral fellowship here at Emory. He conducts diagnostic evaluations and therapy with individuals with ASD and their families in both English and Spanish. And he has cognitively based compassion training instructor certificate at senior level from Emory, and this allows him to investigate and apply clinically the CBCT to families and providers, and to teach CBCT nationally and internationally to populations under high stress in order to foster resilience and social competence. He's traveled all over the world providing this therapy. And his recent work has led to 1 peer-reviewed article, 3 book chapters, and he has been covered by CNN. His talk will focus on compassion training as a way to reduce disparities in the ecosystem of care for autism. So welcome, Samuel.
Thank you, Celine, and thank you all the panelists. It's my privilege and my responsibility to take all these messages home. I also have to acknowledge the organizer of this conference. And let's start by segueing into my presentation from Jennifer's talk. What do babies need? And babies need attention. What do all need? We need attention. We need to pay attention to each other. We need to receive attention from each other. We need compassion. I'm going to propose here this compassion training, and specifically cognitively based compassion training protocol developed at Emory as a possible strategy to reduce disparities in the ecosystem of care for autism. My presentation focuses on the individual level, while acknowledging that many of the difficulties are structural and systemic. We are powerful as individuals. And we are powerful because we are biased. It seems like a contradiction, but we can do. Actually, Salim spoke at the beginning about this old study from 1996, which to my knowledge has not been replicated, but actually highlighted something that it has been seen over the presentations, the role of socioeconomic factors beyond racial differences. And in this study, actually professionals of psychology, I'm one of them, given the same list of symptoms, the same vignettes, symptoms for ADHD or autism, they were more likely to diagnose autism when the socioeconomic background of the family was high, meaning that whether white or black children, they were more likely to diagnose autism if the family came from a higher socioeconomic background for both ADHD and autism symptoms. Actually, this is not new. We have known for many years the importance of cultural competence, of being sensitive to the cultural idiosyncrasies, characteristics of the people we have in front of us. The other Jennifer Sang also mentioned the importance of a good communication. And this has been suggested in psychology, at least if not before, since the writings of Su and Su in 2002, promoting or giving these suggestions for professionals that wanted to be culturally competent, which started, according to them, in the awareness of self, the awareness of the professional, knowing where we stand, what we believe, what is our background, what is our socioeconomic status, what is our preference, what are our likes, going to the knowledge of the person, the family, the child, you have in front of. And of course, we cannot read about other cultures in a manual, but perhaps we can start by asking and spending a little bit more time, which actually the emphasis on productivity doesn't allow us as much. Then if we have the awareness of self and others and the skill and the knowledge of others, we will be able to develop the skills, the different techniques for different clients. Psychology and science is universal, but it has to be personalized. And we also heard Dr. Magaña say that equality is not equity. Each person has different needs. That's why I don't love the word cultural competence. It's more common to talk about cultural humility, and still I'm going to vindicate another word, social competence, because it includes not only nationality or race or ethnicity, but also social family status, religion, even gender, and any and every personal characteristics of the person that we have in front of us as professional. And again, this is about a professional bias, but I'll be speaking tomorrow about what parents, what families can do to also empower themselves and address disparities at a personal level. More eloquently than what I'm saying right here, right now, my fellow Atlanta native, Martin Luther King, explained very well what compassion has to do with being unbiased. People fail to get along because they fear each other. They fear each other because they don't know each other. So this is it. And we're never gonna know each other if we don't pay attention to each other. The bottom line is that actually we don't only not get along because we don't know each other, we also don't get along, and we have a lot of biases because we are stressed out of our minds. And healthcare professionals are one of the populations at a higher risk of severe distress, mental and physical illness than employees of any other industries. Families have it hard, healthcare professionals don't have it easy either. And surprise, of course, this adversely affects the quality of patient care, the communication Jennifer was talking about. However, we know by now that the practice of mindfulness meditation is a very effective tool associated with reduction in health professionals. So we have a hand on the stress. What about the social skills, the social competence or cultural competence that I spoke about? This is where CBCT, cognitively based compassion training, comes handy because it is a mindfulness and compassion protocol for meditation practice. And this means that it targets emotional self-regulation and social regulation, like we want our babies, our children to learn precisely, which we don't practice enough. This is a secular and analytical developed at Emory University, empirically validated in other populations. And you see the photograph of Dr. Nagy, the author of CBCT. We know by now, excuse me, that CBCT practice on individuals without prior experience 8 to 10 weeks of this training actually was associated with a reduction in immune inflammatory distress. And this is the interesting part that perhaps other mindfulness techniques don't show: enhancement of empathy when reading emotion in other faces. This is one of my last slides. This is unpublished data. We were very fortunate to publish the results with the families, but not with the providers at the Marcus Autism Center. What I want to point out in this slide is the reduction in stress. You see here 3 scales, most of which are actually showing significant improvements before and after the 8 to 10 week course. The control group, who didn't take the training, didn't show any significant effects. We had significant improvement in stress and behavioral flexibility. Problem solving is one of the resources that we have in order to reduce stress. And mindfulness, the aspect of paying attention, is actually good to reduce our stress. What we saw as well was an improvement, marginally significant, in acceptance of the particular conditions that we'll have to face, the difficulties of your environment. There was a significant result in one of the scales of this empathy and compassion scale, and very interestingly, the social competence. And we used here free web-based questionnaire, which was cultural competence checklist, and it showed a significant improvement in this measure compared to the control group. So the conclusions are very simple. Compassion can be trained. CBCT, cognitively based compassion training, may be a feasible training for therapists of children with ASD, as it has been demonstrated for parents of these children, with potential benefits on their stress and their social competence, which in turn could help overcome disparities in the ecosystem of care for autism at an individual level. I just want to say we'll have a breakout room with the formidable Karen Guerra soon, so stay tuned. And tomorrow as well for an extension of this presentation, including the results with the families. Thank you very much.
Thank you, Samuel. That was fantastic. And this really is an impressive panel. And it has just been amazing to listen to it. Even though I know all of you and know your research so well, it really blows my mind that it's exciting work, but also understanding how far we still have to go. So we now have some time for a discussion here, question and answer. And so actually, did I just share my screen? I wanted to share.
No, Jareen shared her screen. Jareen, could you take that off and allow?
Oh, I did. I got it. So,
you got it. Good.
I just wanted to mention one thing, Leslie, before turning it over to you, is how this panel fits into the Autism Plan of Georgia. And if those of you who know all the rays, I think there are now 9, if not, there were originally 10 rays. And disparities are one of those overarching issues that just pervades through every single one of the rays of the autism plan. And so we need to be thinking about these disparities, whether it's from, very early on screening, detection, diagnosis, all the way through the lifespan across medical, you name it, issues, it's there. And I think this panel has nicely highlighted that. So with that, Leslie, I'll turn it over to you for Q&A.
Thanks, Celine, and thank you for drawing the attention to the Autism Plan of Georgia and its relationship to health disparities and disparities in general. Again, I agree with you. The panel was just amazing, and I think that they complemented Dr. Manganya's presentation of earlier in the day, and I think overall we've got a little more insight into what the health disparities are in relation to autism diagnosis and management and outcome. and we also have some ideas on what we can do to improve the situation and promote health equity. Selene, if you could pull up the cycle diagram for me one time just before I answer all the questions, and we're going to move to that.
Is this the cycle? Do you guys see
No,
it?
no, I don't see it. That's the autism plan for Georgia.
Oh, you're still seeing that?
Yeah, so.
Oh, I don't know why. It's on, okay.
Selene, this is Green.
Yeah, I'm going to share it again.
Yeah.
I think, okay, here we go. Got it. And here. Now do you see it?
Perfect. Thank you so much. I just wanted to bring you all back to this diagram we created, looking at as many aspects of the disparities in diagnosis and services and therapies and outcomes that we could think of. So I'm going to leave this slide up as we begin to answer the questions. And I'm going to give Dr. Manganya a chance to ask her question. Dr. Manganya, if you have any comment before I get to all the other questions that are on the list, would you like to open up your unmute and comment on the presentations and ask your question, please?
Yes, great. I really enjoyed listening to all the presentations, and I think on your wheel, you know, the presentations really address different aspects of this whole process. And I think I really enjoyed Dr. Staples' presentation about intervening at a very young age with children. I think that's super important, and we have to figure out how we can do that for underserved communities. So my question was, a couple of people on the panel talked about telehealth as a way to reduce disparities. And I'm wondering what you do about rural families that don't have internet. How would you give them telehealth?
That's a great question. That's something that came up in our study, is that there were some families that didn't have devices or only had an iPhone and were very limited in their technology. And so for me, I always try to do as much in person, but if you remember from the grid of Georgia, we would have one participant 5 hours east and one participant 5 hours west. So we used telehealth to bridge that, but for those that didn't, it was a disadvantage.
And I think right now we're seeing with COVID-19 that there probably are families who were receiving Part C services prior to all of the providers being told you can't go to anybody's home, it's not safe to do that, and they were probably offered telehealth services, and there would have been an inability for them to take advantage of them because they either don't have the device they need or they don't have the bandwidth they need, and there isn't an unlimited supply of money to provide like a mobile Wi-Fi of some kind. That is a barrier that I think we're probably seeing right now, and I'd be really curious to ask my Department of Public Health colleagues whether they're collecting some data on children who've had to have their services cut off because of that. I think that Susan's right. I think being able to have a provider go in person is very powerful. So that gives us a sense of how the telecoaching can be used really effectively, which is to sort of expand the network of people who know how to coach parents and know how to intervene, and those be people who are in those communities. And I think that that's one of the things that we have seen be most powerful, is that we can take the knowledge that we may have in the big cities about autism and say, how can we get the folks who live in Southwest Georgia to understand more about what they're seeing, what to do, how to coach parents, because there is some power in them being able to go physically to the families. I think outside of research paradigms, we haven't figured out a way of funding a a clinical model that allows for bandwidth along with it. And that's potentially the next horizon that we're going to have to meet, because who knows what COVID's going to present us with as an opportunity and a challenge to meeting the needs of these young children.
Yeah, and I think that that's an advocacy point for all of us, right? Because this is a macro issue in our communities. Like, how can we push for the cities, the state, and so on to provide Wi-Fi services for everybody? Shouldn't that be a right?
Yeah, absolutely.
I mean,
especially in this day and age where travel and access to in-person services are limited. So thank you so much. Susan Brasher, did you have anything to add? I would like to move on because there's quite a lot of questions. Thank you, Dr. Manganya, for your raising this very important point, which is not resolved, but as you point out, this is something we need to pursue. And I just want to make one more comment that's general, is that we've by no means solved the problem, but we've just added some questions and we've added some action items. And I think it should mobilize us all to move forward to promoting as much health equity as we can in our time available. Susan.
Yeah, the only thing I would add is just that I think in a way we're finding these odd positives of COVID-19, and I think this is one of them, is that it's shined a light on this disparity of, you know, everybody thought it was going to be so easy to take our children to homeschooling online, and not everybody has a device or has Wi-Fi, and so I think this situation really shone a light on that, and so I think that can translate to telehealth and services.
Thanks, Susan. I'm just going to move on to the questions, and I know there are many questions. We may not answer them all, but I'll choose one per presenter, and if there's time over, we'll ask the other ones. So the first question for Teal was, and now it's kind of disappeared. It was relation to special education services and misdiagnoses. So Teal, if you would answer the question. I'm trying to find the
Certainly, I answered it by typing the response, but I can.
Oh, you did.
That.
Fantastic. Yeah. Okay. So did you answer all the questions? You want to make some comments for the general audience on the questions and answers?
Sure. So people were asking how subjects were identified as misdiagnosis. So we did that in 2 steps. First, we identified the number of children in that county using census records. And then using CDC estimates of autism, we identified what we would expect to see in that county with that total number of children between the ages under 20 years of age. And we compared the expected cases with what we saw as actual cases from those school district records. And so the difference between the expected and actual is what we consider to be missed.
Could I add to that? Because the CDC also did a wonderful study this past year when they used their criteria for doing the surveillance for the epidemiological study and applied it to children in the schools who did not have an ASD diagnosis by eligibility in that school district, but they did meet the CDC criteria, and a high proportion of those children were African American Hispanic. So basically they were not given a true autism diagnosis, despite the fact that they were meeting CDC criteria.
Yes, and that's what we found, but it wasn't necessarily related to race or ethnicity or a proportion of county level estimates of underrepresented minorities. Really what we found was that the school districts that had low county income was what was most predictive of those missed cases. So we need to be considering things such as how resources at that school district level to identify and support children in those counties is impacting the kinds of identification and care.
Absolutely.
Yeah, and I'd like to supplement that as well to say that kids who grow up in poorer communities, obviously low tax base and low financial support for schools. So the schools have less resources, the teachers are less well paid, the teachers may not be as motivated. And so the kind of complex, compounded and incremental sort of insults, as it were, of lack of early diagnosis, lack of early intervention, lack of good education, limited educational resources for the kids. And it's not surprising that the data that Dr. Manganya showed was that the kids, and this is by sort of racial identification as a proxy for low-income communities, show a greater degree of intellectual disability than do the more affluent and whiter communities. So we're dealing with a systemic and systematic set of factors that really compromise individuals' opportunities, and we have a lot of advocacy to go for. And I do like the fact that we not only looked at some of the issues, but looked at some of the solutions. And there was a question for Samuel on CBT sessions and how much time does each session take? Samuel, do you want to tell us about that?
Yeah, the study, the evidence available is for courses that last 8 to 10 weeks. I'm doing a lot of intensive trainings, and particularly now with this pandemic and the resources available, we have not seen evidence of we don't have studies on the effects of these intensive courses. But my own experience is that the course, the CBCT training, is just the beginning. What really makes behavior change is practice. We psychologists, and everybody knows that, right? Repetition. But it's necessary to start with the awareness and the intention to get better and do better. So in summary, the answer is that it's 8 to 10 weeks. That is what we know that has very striking effects, but it's now available in an intensive format, 2-3 days. And you, anybody can go to compassion.emory.edu, or even to my website, www.samuelfernandezcarriba.com. In Spanish, you add the bar, ES bar. Sorry, I have a long last name. That's part of my idiosyncrasy. It's been from Spain.
As Samuel, that's part of your charm as well. So, there is a question for Jennifer Singh. Jennifer, what methods of qualitative analysis do you use?
So I was trained in qualitative analysis on grounded theory. So that is the approach that I take in my analysis. So really starting with the data itself and generating codes based on particular themes that come up over and over again. And so it's really a systematic way of analyzing qualitative data. It takes time, and I use a software program that helps with that process. I hope that answers the question.
Yeah, I hope so. The next question is for Susan Brasher. The question is, what are the main differences and disparities between the medically underserved areas and rural communities? Are they mostly similar or different?
There were some similarities, but there was also some differences. So some similarities were the cost and the limited providers, because medically underserved areas don't have providers just like rural areas don't. And then there are some differences though for distance. The rural areas, distance was more of a barrier versus those medically underserved were a little bit closer to the access areas. So there were some similarities and there were some differences. I should really distinguish those. I should think about that going forward to show that at the end of the day, they both faced a lot of adversities to receiving a diagnosis and treatment, but there were some unique differences.
Thank you. There was also another question for Teal about the identification of educationally related disabilities in those poor counties, and the higher levels of other classifications such as intellectual disabilities. And I think Dr. Manganya also kind of raised this as another issue. So I wonder, Teal, if you would address that question, please.
It is an important question. So the diagnostic shifting, so whether or not those children were labeled with some other educationally relevant classification to receive services, as others have raised the point that sometimes children on the spectrum from racial and ethnic minorities are not given a diagnosis of autism, but given some other label such as emotional or behavioral classification. We did not observe that in our data, but we didn't specifically examine that question, but it is an important one to continue to look at as to whether or not that diagnostic shifting occurred and possibly those children were labeled as something else.
Okay, thank you, Teal. There's another question. It's a kind of a statement. It says, are there differences in types of special education services offered in different areas of Georgia? So I think I'll leave that to any panelist who wants to answer that question. But it would probably be Teal and Susan who would address those.
I think that's a great question, and I'll invite anyone else who wants to jump in. It is likely that the service provision differs across counties, the number of providers in each of the counties, and that is an important next step that we needed to do. We only have county level estimates of number of primary care providers in that county for county level estimates, but in order to identify the number of special education providers and others, we're going to have to do some more digging, including OT providers, PT, speech language pathology, etc. But I would welcome anyone else who wants to jump in on that question, and that work does need to be done.
I would love to add that just there's a difference between quantity and quality as well throughout all of these districts. And, you know, there could be areas where there's lots of opportunities for intervention, but the training and the quality of that intervention is not fantastic. And so I'm thinking just Jennifer Staple-Wax and the work that you've done, and, you know, the areas where you've been able to infiltrate and coach those early intervention providers, for example, or Emily Rubin has gotten to social emotional learning in the classrooms. So, you know, you guys are breaking ground in lots of places, but obviously haven't gotten everywhere yet.
Yeah, I would just add to that from what I was hearing from the parents that there was a lot in the more so in the rural areas, that the lack of in school therapies and lack of the differences in the IEPs and some of the things that they had access to in the rural areas was far less, both in quantity and quality. And so in some areas they had no school speech language pathologist or OT or physical therapy, and then in some they had one, but like you said, the quality they were not. They did not find it was high quality.
Thanks, Susan. There's an excellent question that appeared, which is, what role do parents of children with autism play in early intervention? And what I'm going to do here is go through each of you, each presenter, because I think this cuts across every presentation. So we'll start with Teal, because you were the first presenter. So would you give a comment on what role the parents of children with autism play in early intervention?
I think that's an important question. So parents play an integral role in helping their children identify resources for their children in the community and ensure that participation occurs in whatever capacity that parent wants their child to be involved in the community. I'm a big proponent of parents bringing those kids along and making sure that they have every opportunity to be exposed to experiences and daily life opportunities. And parents really have an important and unrecognized job in taking on understanding the services and supports, and also being that loving provider. And as was mentioned, you know, just being present in their child's life. So I want to shout out to all the parents that are out there. And I'm sure everyone saw my daughter run by in the background. Sorry.
No, I think that's a wonderful statement. And I'd just like to interject my common comment to parents when they say to me, what can I expect in the future? Or what can I do? Or what's my child going to be like in 10 years, in 20 years? I say, we don't know, but we know that there are three major elements that are going to help your child make progress. Number one is your child's potential that the child was born with, that we need to cultivate. Number two, parents' love and attention is indispensable. Without that, you're not going to go anywhere. So parents' love and attention. And the third element is the resources in the community, which are therapeutic, educational, vocational, and the like. So that's my little 2 cents worth. And I'll move on to Susan Brasher, who was the next presenter. Susan, what role do parents of children with autism play in early intervention?
I think for me, it's just a step before early intervention, and just that they're such powerful, strong advocates, and then they see the signs and symptoms in their children and they're often dismissed. And so the persistence of that role that they play, and so just being persistent, advocating. And then I think, Jennifer Staple-Wax will probably say this, or she might have already had, but the parents are their children's first teachers. And so kind of thinking about the role that they could play in early intervention. So even without access to those services, what parents want to help their children, and they want to play a role. And so finding how we can help lift them up into that role.
Oh, fantastic. Excellent. Jennifer Singh?
We just lost her.
Jennifer,
I just lost. Okay. There we go.
Yeah.
There we go.
There you are.
Technical difficulties. I want to emphasize everything that everybody has said, but just to really, the thing that I've learned most from parents is to really trust your knowledge and how important your knowledge is in understanding your child more than anybody else. You're with them all the time, and you know your children well. And so really trusting that, advocating and learning what you can. There's been a couple of different resources that have been shared on the chat that offer videos, that offer tools and guidance. And certainly it can be overwhelming. But sticking with programs that have shown success and evidence to support that success is really important. But just really trusting your knowledge. The thing that I learned by observing at the clinic is really how that knowledge is then shared and utilized in developing these plans. For your child as well as for your family.
Thanks, Jennifer. Jennifer Staple-Wax.
So I'm going to definitely come in on the side of very early intervention, because it struck me that when we use the word early intervention, what that has meant over time has changed quite a bit. We used to think about early intervention as like, oh, surely, like if we can get to children by the time they're 4 or 5 years old, that's early intervention. And we now really think about, and mind you, for some children, that still is early intervention, but we're really increasingly trying to get into the window of the first 2 years of life. And I think that panelists have made this point, and I think that this is really important, is that all parents are excellent advocates for their children. Whether their child develops autism or does not, parents are learning a lot about their children's developmental milestones, about how to keep them engaged in everyday life. And I think that parents really are their child's first and best teacher. And we owe it to those parents to provide them with the best examples, the best education, the best coaching, the best opportunities to build their own knowledge, and to bring that knowledge to them, to their doorstep. And I think that there are a lot of really nice tools out there now to do that, and to help those who are interacting with those parents to to coach them along. I think it's very easy for parents facing a diagnosis of autism to say, oh, well, I've got to depend on the experts. And I think it is really important to put that ownership back into a parent and say, you're the expert. You know your child best. You know what they look like when they wake up in the morning, and you know what they look like when they go to sleep at night. And so your voice is incredibly important, and your actions are incredibly powerful. So I can't say enough about the importance of parents and caregivers in the life of children with autism.
Thank you, Jennifer. Samuel? Unmute, Samuel, you're muted, so.
Sorry. Thank you so much. So much wisdom in the room, not only from the panelists, but from all the audience. And I wanted to reinforce what has been said already by many of us. You are powerful, you listener are powerful. And I believe we are coming to a change in the paradigm of how we provide health services, from being, from giving instructions, which in a way took away the power of families and their own circumstances and their own knowledge. We are coming closer to be more coaches, sharing what is universal. Science is universal, but let's not forget that science has to be personalized, implemented in your particular situations. And for that, you, the listener, is the only one who could do that with our help. So I think we are at a very exciting point in science, in which there's also all this empirical evidence that supports the role of love and compassion, and the role of attention that, yes, can be practiced, can be trained. William James, the father of psychology in America, said that attention cannot be trained. And now there's data that suggests that he was mistaken. So again, in summary, it can be trained, and a course is just the beginning, but what you do on your everyday life impacts your children. And I like to joke around with my friends. I take these trainings and I teach these trainings for their own sake, for those of who are not taking them. So I get better, and that way I impact others. And number two, there's room for your intuition, for your knowledge, for your information. Let's not discount what we know, but like, again, Dr. Magaña said, equality is not equity. We need something universal, but it has to be applied to cover whichever needs each one of us has.
Thanks, Samuel. My co-moderator, Selene, has the last word.
Oh, I was just going to say there was an addendum to the question about language barriers in that intervention. I wanted to bounce it back to Samuel, but to emphasize to all the parents out there from bilingual and multilingual families that there is absolutely no evidence from a speech-language communication perspective that intervention in one language hinders the development of language across languages. So always keep your native language in the home, even if the intervention is conducted in a different language.
Thank you, Selena. A wonderful tribute to individuality and promoting individual children and families to be their best and capitalize on their strengths, rather than try to modify those to some kind of standard. Thank you, the moderators. Thank you, the speakers. Thank you, Dr. Magaña. Thank you, the organizers of this conference. This has been an excellent panel. This has been an excellent afternoon, and I hope we will see much more of this in the future conferences of the Expo and nationally.